today. She gets the award for having the best pediatric grand rounds title of the year. And she's going to be talking about neonatal fever, how to approach hot babes. Dr. Kalra is a graduate with her medical degree from the American University of Antigua. She is, of course, one of our graduating pediatric residents, and I've had the pleasure to work with her every week this year in continuity clinic, and can say she's very skilled in managing sick patients and also coordinating care for children who are fairly complex in the primary care setting. She is going to be joining the ANOVA group as a pediatric hospitalist in Fairfax, Virginia in July when she graduates, and I think that's a perfect job for her, and I know she will excel at that. She, during residency, has been awarded Residence of the Month multiple times. She has been involved in research prior to residency that has been published and has been involved in case report presentations multiple times during residency, actually in the fields of infectious disease. She's also provided leadership on a number of different administrative and quality improvement committees during her time here. So before we let her start, I just want to say welcome to her husband. Thank you for joining us. And I'll turn it over to Dr. Kalra.
Thanks, Dr. Skitzina. So hello, and thank you everyone for coming to my Grand Rounds presentation. So today, as you can tell from the title, we're going to talk about neonatal fever. And so I chose to talk about this topic today because when I was an intern, we had a hospitalist who drilled this topic into our head over and over again. And it really was one of her favorite topics to talk about, and it's actually stuck with me ever since. So without further ado, let's go ahead and get started. So I have nothing to disclose. So the goals and the objectives of today's lecture are really to define a true fever in a neonate and to discuss the types of measurements that we can use to obtain these fevers. And we'll also review the different causes of fevers and the risk factors for serious bacterial infections. And we'll talk about the traditional evaluation that's currently used in medicine for the treatment of and the guidelines for neonatal fever. And also we'll review the treatment that's currently used as well. But I also wanted to introduce some new literature that's out there regarding like the new methods and approach for neonatal fever, but it's also controversial, so we'll just talk about it. And then we also do have some cases and some scenarios at the end of the presentation as well. So before we kind of delve into the guidelines and the treatment for neonatal fever, I did want to go ahead and introduce 4 cases. These are just generic random cases, and they actually bear no resemblance to cases that we have dealt with on the pediatric floor. But for now, just keep these cases in the back of your mind, and then we'll review them as we come to the end of the presentation. So the first case that we have is baby A, who is a 6-day-old male infant who presents to the pediatric ER with a reported temperature of 101.6 rectally. And mom has also noticed some increasing irritability, some decreased feeding, and a decrease in the amount of wet diapers. And you're the pediatric ER who's attending who's in-house, and so what would you do? The second case is baby B, who is 39 days old and is a girl who presents to her primary care physician with a reported temperature of 100.8 at home. And mom kind of reports some typical upper respiratory symptoms with difficulty breathing, congestion, cough, and decreased oral intake. And the primary care initiates transfer to the hospital. And you're the on-call hospitalist who's accepting this patient. So what would you do? And the third case is baby C, who is 25 days old, is a boy, and he comes to the pediatric ER with a reported temperature of 101. Mom really denies any associated symptoms along with the fever, but a limited septic workup is obtained in the ER, and the respiratory viral panel is positive for rhinoenterovirus. But no antibiotics were initiated at the time of presentation. And again, you're the on-call hospitalist who's accepting this patient, so what would you do? And the last case is baby D, who's a 42-day-old female who presents to her primary care physician with a reported fever of 103 at home. And mom reports some decreased oral intake and urine output. And the primary care physician is so gracious to obtain some basic lab work. And the basic lab work is concerning for a possible UTI. And so they decide to initiate transfer to the hospital. And again, you're the on-call hospitalist accepting this patient. And so what would you do? Okay. So how do we really define a fever in an infant? So studies have shown that the accurate method to actually check for a fever in an infant is rectally, especially those who are less than 3 months of age. And a true fever is really defined as anything that's greater than or equal to 100.4 in infants who are 90 days or younger. And parents are also advised before they are discharged from the nursery not to routinely check any temperatures unless the infant is acting fussy, is just not acting right in general, or just feels warm to the touch. So where did we kind of get this number of 100.4 from? So there actually have been multiple studies done that have actually looked at kiddos who are less than or equal to 90 days of age, and they looked at the risks of serious illnesses in these infants, and the value of 100.4 corresponds to a value that is 2 standard deviations above the mean in this age group. So moving on to the types of measurements. So again, like we talked about previously, rectal temperatures are the most accurate method and the most preferred method. And it generally is preferred to use electronic rectal temperatures with covers, electronic thermometers with covers. And there's actually certain temperatures or certain conditions in which rectal temperatures are contraindicated, which include neutropenia, thrombocytopenia, and necrotizing enterocolitis. And that's because the rectal approach actually includes trauma to the rectum, as well as a potential for secondary infection because of perforation. So it's contraindicated in necrotizing enterocolitis for the potential of spreading infection at the risk of sepsis and hemorrhage. And it's contraindicated in thrombocytopenia because of the risk of perianal bleeding. And it's contraindicated in neutropenia because of the risk of generating infection in the perianal or the perirectal region. But again, rectal temperatures are the most accurate method in order to obtain these temperatures in fevers, or in kiddos. So axillary, temporal, and tympanic membrane temperatures can be obtained, but in general, they're actually less reliable. And glass thermometers should actually never be used because they're harmful if they're broken, and they also have a potential for spreading infection if they're broken inside of the rectum. So moving on to the causes of fever, viruses are actually the most common causes of fever, and the more common causes that we do see are enterovirus, influenza, adenovirus, RSV, HSV, and VZV. But fevers can also be caused by serious bacterial infections, which is really what we're trying to rule out and why we do such an extensive, thorough workup in the first place. And so common sources of these bacterial infections include E. coli, GBS, Listeria, Staphylococcus aureus, strep, and enterococcus. And they can present as pneumonia, bacteremia, meningitis, acute gastroenteritis, UTIs, or skin or soft tissue infections like osteomyelitis. So there was actually a study that was done in infants who were less than 28 days of age, which showed that 17% had an identifiable viral pathogen, whereas only 14% had a serious bacterial infection. And there was another prospective study done, which included 1,779 infants, which showed that 35% of them had an identifiable viral pathogen, whereas only 10% had a bacterial pathogen. So these infections can actually be transmitted vertically from mom to baby, and also postnatally from an outside source, such as family members and or hospital personnel. And infants who are less than or equal to 90 days of age actually have an increased morbidity from viral pathogens because of a decreased responsiveness to T-cell immunity. So E. coli and GBS are the most common cause of bacteremia and bacterial meningitis, whereas E. coli alone is the most common cause of urinary tract infections. Listeria is actually becoming less prevalent. We do see a few cases here and there, but in general, it's actually become less prevalent. But it still is important to remember that it's an important cause of bacterial meningitis in kiddos who are less than 28 days of age, or if they're premature. And Staph aureus is actually on the rise, and we've seen a few cases of Staph aureus bacteremia, but it's also the most common isolate from skin or soft tissue infections. And urinary tract infections account for most of the bacterial infections that we do see in kiddos who are less than or equal to 90 days of age. So there was a study that was done, or well, several studies that were done, one of which included 440 infants, and 80% of those infants were diagnosed with a UTI. And there was another study that was done which included 1,035 febrile infants who were 60 days of age or younger, and they were evaluated for a fever greater than 38 degrees Celsius, and 9% of those were diagnosed with a urinary tract infection. And then in boys who are uncircumcised, there was a study that was done that 21% of those boys were diagnosed with a urinary tract infection with a fever of greater than 39 degrees Celsius. So ever since we've introduced the Haemophilus and pneumococcal vaccines, we've noticed that the incidence of pneumococcal and Haemophilus bacteria has since decreased. And there was actually a study that was done in 2006 which showed that they actually evaluated a fever in kiddos between the ages of 57 to 180 days of age, and they included blood and urine testing as well as nasal swabs for respiratory viral pathogens. And the total number of patients included in that study was 429 infants. And of those 429 infants, 44 of them were diagnosed with a serious bacterial illness, where 41 of them had bacteriuria and 3 of them had bacteremia. And 52 of them underwent an LP and revealed no cases of bacterial meningitis, and only 1 of them was diagnosed with pneumococcal disease in the post-pneumococcal vaccine era. So what are some of the risk factors for serious bacterial infections? So we have an age as less than 28 days, ill appearance, erectile temperature or hyperpyrexia as greater than or equal to 104, an unimmunized status, prematurity, recent antibiotic use, social barriers to follow-up, and maternally transmitted infections. So being an age of less than 28 days of infection, for those who are unimmunized, because we don't get our first set of vaccines until we're 2 months of age, puts you at increased risk for development of these serious bacterial infections. They also have a lack of a developed immune system because they're so young at this age, and there's also a risk of transfer of maternal infection as well. And there were several studies, including observational studies, that reported a higher incidence of serious bacterial infections in this age group, between 9 to 19%. So ill appearance, again, multiple studies have shown a correlation between ill appearance and serious bacterial infections, but they've also shown a correlation between non-ill appearing infants without a focus on physical exam and serious bacterial infections as well. So hyperpyrexia in general to see in little kiddos is rare because they have a lack of a developed immune system, so it's harder for them to mount such a surge of an infection. And so there was a study that was done which showed that there was a 29% absolute increase in the frequency of serious bacterial infections associated with an elevated temperature. But there was also another study that was done which showed that if the temperature was greater than 102.2 in kiddos who were less than than or equal to 90 days of age to go ahead and perform a full septic workup because they are at increased risk for serious bacterial infections. So an unimmunized status, again, like we've talked about previously, if you haven't had your first set of vaccines at that 2-month mark, including your Pneumovax and your Haemophilus influenza B vaccine, it does put you at increased risk of serious bacterial infections. And ever since we've introduced those vaccines, we've seen a decrease in the incidence of bacteremia. But I did want to mention that there was an observational cohort study that was done evaluating unimmunized versus immunized children, and they included 50 immunized children versus 67 unimmunized children, and the rates of serious bacterial infections were a lot higher in those who were unimmunized at 7% versus 0% in those who were immunized. So again, prematurity or having an immature immune system puts you at increased risk, but the rates of sepsis are actually a lot higher in premature infants at about 10 to 12% when compared to a term infant. But after they've passed that post-conceptual age where they actually have a similar incidence of serious bacterial infections as compared to term infants. So recent antibiotic use, a lot of the antibiotics that we use, whether it's for acute otitis media, pneumonia, or urinary tract infections, they all actually have long half-lives of antibiotics. And usually the duration that we give the antibiotics for is approximately around 7 days. And these antibiotics that we do administer in these kids can actually mask the signs or symptoms of serious bacterial infections as well. Social barriers to follow-up, which unfortunately we see a lot here in this area. There is an educational barrier. There's limited caregiver because of disability or due to their own illness. There's limited access to physicians, whether it's due to a lack of transportation or just unwillingness to come. And then a language barrier, which is seen a lot here as well. And then maternally transmitted infections. So chorioamnitis or maternal fever, having a prolonged rupture of membranes or positive maternal GBS status, as well as inadequate intrapartum prophylaxis and maternal genital herpes all put you at increased risk for serious bacterial infections. So now moving on to evaluation. So evaluation can actually be broken down into 3 different categories. So you can have a febrile infant between 0 to 28 days of age, a febrile infant between 29 to 60 days of age, and then a febrile infant between 61 to 90 days of age. So for right now, I kind of just want to stick to the traditional guidelines that have been kind of used rather than delving into the literature that I've read, and we'll kind of get to that a little later. So for an infant who is less than or equal to 28 days of age who presents with a fever, really a full septic workup according to traditional guidelines should be obtained, which include a CBC, a CMP, a blood culture, urine analysis, urine culture, a respiratory viral panel, which typically is mostly present in our hospital, and lumbar puncture with CSF studies. So this is a chart that kind of summarizes the approach to the febrile infant who is less than or equal to 28 days. Sorry if it's kind of hard to see. I tried to blow it up as much as I could. So the way that it's broken down is into afebrile infants versus febrile infants. And so really the gist of the flow chart is that if the infant is afebrile and relatively well appearing, that it's okay to go ahead and reassure the family and it's okay to send the patient home. However, if the patient is, or the infant is febrile, and regardless if they're well appearing or ill appearing, to go ahead and perform a full septic workup, admit them to the hospital, and go ahead and start empiric antibiotic therapy. However, if the child is not well appearing or if they're showing signs or symptoms of autonomic or hemodynamic instability, please go ahead and start the empiric antibiotic coverage if you think that they're too unstable for a workup. So for infants who are between 29 to 60 days of age, a limited septic workup should be done, which includes a CBC, a CMP, a blood culture, urine analysis, urine culture, and a respiratory viral panel, which again is mostly in our hospital. And you can do a plus or minus lumbar puncture with CSF studies. So regarding whether to LP or how long to monitor them for or how long you need to do or if they even need antibiotics at all really depends on if they're high risk or low risk and which criteria you choose to follow. So there's 3 different criteria that are there. There's the Rochester criteria, there's the Philadelphia criteria, and the Boston criteria. And I do want to take the time to talk about all 3 of those different criteria. And please forgive me because I will be flipping back and forth between several slides to try and show you as many charts as possible. So we'll start with the Rochester criteria, just because it's most commonly used and it's actually one of my personal favorites. Okay, so really what the Rochester criteria is looking at if they haven't received any antibiotics postnatally, if they're well appearing, or if there's any signs or symptoms of focal infection. And from a laboratory standpoint, they're looking for a white count between 5,000 to 15,000, an absolute band count of less than 1,500, and a urine analysis with less than or equal to 10 white blood cells per high power field. And if there's diarrhea present and you do get a stool smear, if there's less than 5 whites per high power field on the stool smear. So what does this kind of mean? So if the infant actually meets all the criteria present in the Rochester criteria, then he or she is deemed to be low risk, and it's okay to reassure the infant and you don't need, or reassure the family that we don't need to obtain an LP. But it also indicates that the occult bacteremia risk is about less than 1%. So the sensitivity of the Rochester criteria is about 92%, whereas the specificity of the test is about 50%. So the Philadelphia criteria also looks at clinical evidence versus laboratory evidence. And really what the Philadelphia criteria is looking for is really a well-appearing infant without any signs or symptoms of focal infection. And from a laboratory standpoint, they're looking for a white count less than 15,000, a band total neutrophil ratio of less than 0.2, a UA with less than 10 white blood cells per high power field, along with a negative gram stain, and then CSF studies with less than 8 white blood cells per millimeter squared, along with a negative gram stain, and then a chest x-ray with no infiltrate, and then again, if there's diarrhea and you do perform a stool smear, if there's less than 5 or few to no white blood cells on the smear. So the downfall to the Philadelphia criteria is that you actually end up having to still go ahead and lumbar puncture the infant, but the advantage to the Philadelphia criteria is that it actually has a higher sensitivity compared to the Rochester criteria. So if you take a look at the sensitivity of the Philadelphia criteria, we're actually at 98% versus 92% in the Rochester criteria, with a specificity of about 42%. So what this means is that if the infant meets all the criteria of the Philadelphia criteria, then it's okay to safely discharge them home without any antibiotics, but they should have close follow-up. However, if they don't meet any of their criteria, then to go ahead and admit them and start them with empiric antibiotic treatments. So moving on to the Boston criteria. Oops. So the Boston criteria, again, they do the whole clinical evidence versus laboratory evidence as well. And the clinical evidence that they were looking for is, again, a well-appearing infant without any signs or symptoms of focal infection. However, there shouldn't be any antibiotics or immunizations within the preceding 48 hours. And then the laboratory evidence, the white count that they were looking for is less than 20,000 with a urine analysis of less than 10 white blood cells per high power field, and then a CSF study with less than 10 white blood cells per high power field, along with a chest x-ray without any infiltrate. So again, the downfall to the Boston criteria is that you have to LP the infant, but the advantage is that this criteria actually has the highest specificity as compared with any of the other two criteria that we've talked about previously, so with a 94.6 specificity. So again, what this means is that if the infant meets all the criteria in the Boston criteria, then it's okay to give them empiric Rocephin or ceftriaxone and discharge them home with a close follow-up. But if they don't, to go ahead and admit them and start some antibiotics. And this is the table that we've kind of been looking at as we've been flipping back and forth. And really, I feel like this table is so helpful in distinguishing between the three. And if you have never seen this table or if you have questions about the table, you can see me afterwards and I can give you the reference. So what are the limitations to all of the protocols? So actually, the Philadelphia and the Rochester criteria, they both have high sensitivities. But you're still sending the low-risk patients home without any antibiotic coverage. Whereas with the Boston criteria, you have a lower sensitivity, but you're still having to perform a full septic workup. You're still having to perform an LP, and you're still having to give Rocephin at discharge, even if they're low-risk patients. So there's actually studies who've actually evaluated the applicability of these various screening tools that we do have, especially in infants who are younger than 28 days of age. And really what they found was that they found an increased number of missed serious bacterial infections in kiddos who are less than 28 days of age. And the authors actually concluded in the study that when using the Rochester, the Philadelphia, or the Boston criteria in infants who are less than 28 days of age, that we'll actually miss about 3% of serious bacterial infections. But also do keep in mind that all of these criteria were created back in 1993 or 1994, and ever since they've been created, our actually microbiology epidemiology has actually shifted drastically. So for the kiddos between 61 to 90 days of age, they've actually broken down the current guideline regimens into two different groups, which are the febrile well-appearing group or the febrile ill-appearing group. And like I mentioned previously, if there is an infant who's less than 90 days of age and if there's concern that they're just ill-appearing, to go ahead and perform the full septic workup, including the lumbar puncture. For febrile well-appearing infants, it's kind of based on symptomatology. You can get a respiratory viral panel, you can test for RSV or influenza, you can get a blood culture, chest x-ray, and you can check the urine as well if there are symptoms of urinary tract infection. So this is actually another flow chart that summarizes the approach for infants between 6 to 8 weeks. And actually, we want to take a look on the right of the chart because that's for the infants between 6 to 8 weeks versus the left is for the infants between 4 to 6 weeks. And really what they're describing, again, is what we talked about on the previous slide. They've broken it down between febrile infants who are well-appearing and ill-appearing and whether or not they need to have certain testing done that we talked about on the previous slide. But for the most part, if they're ill-appearing, to go ahead and perform the full septic evaluation. So again, these are just traditional guidelines, and they've been practiced for many years, but I know that some of us don't necessarily like to follow or use these guidelines, which is fine, but these are the current published and recommended neonatal fever guidelines. So let's kind of keep with this traditional format and move on to the treatment options based on the varying age groups as well. So treatment can be divided into 3 different categories, just like the evaluation that we talked about. So between febrile infants between 0 to 28 days of age, febrile infants between 29 to 60 days of age, and febrile infants between 61 to 90 days of age. So for those kiddos who are less than or equal to 28 days of age, we can use ampicillin or cefotaxime or claflin, or we can use ampicillin and gentamicin. And I know that we typically use ampinclaf on the floor and ampingent in the NICU. And you can do plus or minus acyclovir. So Empiric antibiotic coverage for severe infections like meningitis or septicemia should be given immediately, regardless of what the initial laboratory results show. But like I talked about previously, if the infant is showing any signs or symptoms of autonomic or hemodynamic instability, to please go ahead and start empiric therapy, regardless if the workup has been done or not. Another antibiotic that you can consider using is vancomycin if the infant is showing signs or symptoms of septic shock or signs or symptoms or evidence of focal skin or soft tissue infections. So for the infants between 29 to 60 days of age, we can use ceftriaxone or Rocephin or Ampinclaf again. So again, you can consider vancomycin in this age group if there's signs or symptoms of septic shock or evidence of focal skin or soft tissue infections. But you can also consider acyclovir in this age group if the infant is showing like a vesicular rash or laboratory labs concerning for HSV. But I did want to mention that HSV is actually uncommon beyond 4 weeks of age and is actually exceedingly rare beyond 6 weeks of age. And then for our kiddos between 61 to 90 days of age, we can use Rocephin plus or minus vancomycin. So what are we trying to cover? So we know that our ampicillin will cover our enterococcus and our listeria. And our cefotaxime will cover our gram-negative bacteria like E. coli, H. flu, Neisseria, Proteus, Enterobacter, those types of things, and some gram-positive bacteria as well. And our vanc will cover our resistant Staph aureus species, and acyclovir will cover our HSV. Okay, so now I think it's a good time to transition to some new research that's out there. It's a little controversial, and some physicians choose to use them, and some physicians choose to kind of mix and match between traditional and controversial guidelines. But again, just for simplicity's sake, I've broken them down into varying age groups that we've talked about previously. Okay. So for infants between 0 to 28 days of age, there were actually 2 studies that I looked at that I wanted to share with you. And the first study is the one that's right here on this slide. So this study was done in 2015, and it was published in the Hospital Pediatrics and AAP. And what they did was they compared febrile infants who underwent a full septic workup versus febrile infants who underwent a partial septic workup. And really what they looked at was the readmission rates, the length of stay, and parenteral antibiotic administration. So they reviewed the FISH database, or the Pediatric Health Information System database, between 2002 to 2012. And they only included those with a diagnosis of fever or neonatal fever, and infants between 0 to 28 days of age of any gestational age. But they did exclude those infants who have a complex medical history or those who have been admitted to the ICU. So in this study, there was a total of 27,480 infants included in the study, and 14,774, or 53% of them, underwent a full septic workup, including the blood, urine, and CSF studies. And 3,254 of them, or 11% of them, underwent a partial septic workup with blood and urine studies only. And so they compared the two, but the remaining 34% of them actually had missing data, and so they were excluded from the study. So what they found was that greater than 99% of infants were discharged home, and about 95% of them remained in the hospital for they were discharged within 5 days, but the median length of stay was 2 days. They didn't see any difference between length of stay, readmission rates, or parenteral antibiotic use. But what they did find was that the infants who underwent a partial septic workup were actually more likely to undergo certain laboratory testing or imaging studies, which included like HSV testing, respiratory cultures, LFTs, or RSV testing, and a chest x-ray. So the second study that I looked at was done in 2013, and this study was also published in Hospital Pediatrics in the AAP as well. This was a retrospective cohort study that was done using a micro database, and they evaluated the duration of hospitalization in infants less than 30 days of age who were admitted with a fever. And this study included infants, again, who were less than or equal to 30 days of age, who had blood and CSF cultures obtained between January of 1999 to December of 2010. And again, they excluded those kids who had complex medical conditions or those who were admitted to the ICU. So this study had a total of 1,145 infants who were included, and of those 1,145 infants that were included, there was 1,876 cultures that were obtained. So there was 1,244 blood cultures, there was 632 CSF cultures, and then 580 of them had combined blood and CSF cultures. So of the 1,145 who were included in the study, only 484 were hospitalized for fever without source, but only 408 were included in the study because 71 of them were hospitalized for other reasons, and 5 of them were hospitalized with missing data. So of the 408 who were hospitalized, 31 of them had a pathogenic culture, and 6 of them had a time to notification of greater than 24 hours. And so all 6 of those patients who had a time to notification greater than 24 hours actually met high-risk criteria on admission and were admitted with fever without source. And what they used as high-risk criteria was having a white count of less than 5,000 or greater than 15,000, if they had a band count that was greater than 1,500, or if they had an abnormal urine analysis. So 26 of them actually had bacteremia or bacterial meningitis, but no low-risk patients ever had a time to notification of greater than 24 hours. So the study concluded that about 25% of infants who have bacteremia or bacterial meningitis will actually not have cultures turn positive greater than 24 hours out, and that the absolute risk of having a positive culture result beyond 24 hours is low at 1.5%, and even lower at 0% with those infants with normal laboratory values on presentation. So in the 29 to 60 days of age range, there was only one study that I looked at, and that was done in 2013. But this one was published in the the Journal of Hospital Medicine, and this was a retrospective cross-sectional study. So this study included 33 hospitals that were present in the FISH database, and they looked at differences in the ER clinical practice guidelines, laboratory testing, hospitalization, ceftriaxone use, and costs. And so really the clinical practice guidelines are designed to implement like quality-based or evidence-based care and reduce practice variability. And the goal is to reduce costs and also to improve quality of care. So the study actually included febrile infants who were less than or equal to 56 days of age between January to December of 2013. And so they excluded those who had chronic medical conditions or those who were transferred from another institution. And they surveyed about 37 ERs, but only 4 of them did not respond, including a total of 33. And of those 33 ERs, about 21 of them had clinical practice guidelines. And of those 21, 15 of them had clinical practice guidelines for infants less than 56 days of age. 5 of them had clinical practice guidelines for infants only less than 28 days of age, and only 1 of them had clinical practice guidelines, or CPGs, for infants between 29 to 56 days of age, but not for infants less than 28 days of age. So in regards to laboratory testing, hospitalization, Rocephin use, and costs, they included about 9,377 infants and divided them into 2 different categories, if they were less than 28 days or if they were between 29 to 56 days. And a third of that population was less than 28 days, and 2/3 of them were were between 29 to 56 days of age. And so they looked at the overall serious bacterial illness rate in those kiddos between the 2 age ranges. And you can see that the serious bacterial illness rate is actually higher in the kiddos who are less than 28 days of age at 11.9% versus 6.9%. So what the study concluded was that there was really no observed differences for the kids or the neonates who were less than 28 days of age. And actually, of the 16 hospitals with clinical practice guidelines for febrile infants between 29 to 56 days of age, they all recommended urine and blood testing, except for one hospital who recommended consideration of blood testing but not to obtain routinely. And the hospitals actually varied. They were actually half and half between whether they would like to do a lumbar puncture. Half recommended it, and only half recommended it if they were high risk. And hospitalization was only recommended in those kids who were high-risk patients. So for the low-risk patients who were being discharged, 3 of the hospitals recommended using Rocephin, 9 considered the recommendation of using Rocephin, and 4 actually recommended against the use of Rocephin. So for those kids between 61 to 90 days of age, really there isn't very much data that's present out there. The most concerning age range is between those who are between 0 to 60, and you can always just consider a workup based on symptomatology. So based on what we've kind of reviewed today, I want just the cases that we talked about in the beginning, I wanted to go over those cases and kind of see what you guys thought based on those. So if you guys remember case 1, this is baby A, who is a 6-day-old male. So I personally would go with the traditional guidelines. So the third case is baby C, who's the 25-day-old male who presents to the pediatric ER with a reported temperature of 101. Mom didn't see any further symptoms, but the limited septic workup is obtained in the ER where the respiratory viral panel is positive for rhinoenterovirus. So no antibiotics were started. What would you guys like to do? Okay. So the traditional guidelines recommend to go ahead and do the partial septic workup again and hold off on the LP and hold off on empiric antibiotic coverage. But the controversial guidelines recommend doing the partial septic workup, holding off antibiotic coverage, and monitoring for about 24 hours. And I would personally use the controversial guidelines because if we're only watching for 24 hours versus 48 hours, we're actually cutting down cost on hospital admission. And we've already obtained, or the ER physician has already obtained limited septic workup for us. We already have cultures that are pending and cooking. And so if we have a good phone number that we can reach the family at, I personally would go ahead and hold off on antibiotics and go ahead and send the kid home at 24 hours since we already have a source of infection or source of fever. And the last case is baby D, who's a 42-day-old female who presents to her primary care with a reported fever of 103 at home. And mom reports some decreased oral intake and urine output, and the primary care physician obtained some basic labs, which are concerning for a possible UTI, and the primary care physician initiates transfer to the hospital. You're the on-call hospitalist accepting the patient. What would you guys like to do? So the traditional guidelines recommend a partial septic workup, where you, again, do everything minus the LP, and then to go ahead and initiate antibiotic therapy. And once your urine culture grows something, you can always gear your antibiotics towards whatever your urine culture is growing, but to go ahead and treat for about 14 days. But the controversial guidelines recommend, again, doing the partial septic workup without the LP, and to go ahead and initiate antibiotics and only treat for about 5 to 7 days. So again, personally, if we're cutting down on hospital admission or hospital length, I would go with the controversial guidelines. But at this point, I did want to transition to just a side point here regarding infants with fever and urinary tract infections. So like we talked about earlier, the UTIs are actually the most common cause of serious bacterial infections in infants. And so I actually reviewed 2 studies that I wanted to share with you. And the first study was done in 2015. And again, this one was published in Hospital Pediatrics and AAP. And what it looked at was the prevalence of bacteremia in infants less than 1 year of age with a UTI. And they actually compared the characteristics of infants with and without bacteremia. They described the treatment course and the 30-day outcomes. So this study was interesting in that it had 2 different methods in it. So when looking at the prevalence of bacteremia in infants less than 1 year of age, they used a retrospective cross-sectional design. But when looking at the clinical characteristics and outcomes of infants, they actually used a retrospective double cohort design. And so the reason that I chose to include this study was because clinical practice guidelines do exist for infants with urinary tract infections, but what they don't include is recommendations on when to get a blood culture and for how long to treat them for. So this study actually included about 1,379 infants with urinary tract infections, and they actually defined urinary tract infections as urine cultures growing greater than or equal to 50,000 CFUs by cath specimen, or greater than or equal to 100,000 CFUs of pathogen by clean catch. And so they also defined bacteremia as growth from the blood culture in 24 hours of the urine culture with the same pathogen. So 714 of these infants had blood cultures obtained, and the results showed that compared with patients who are less than 4 months of age, the kiddos who are actually greater than 4 months of age were at lower risk of having a positive blood culture, and they actually decreased annually by about 8%. And they found no significant difference between the 2 groups regarding clinical characteristics of patients with and without bacteremia, aside from the subtle laboratory evidence as mentioned in the slide. So they found that no infants returned with a repeat UTI within 30 days post-discharge, and the treatment actually varied. So the treatment was less than or equal to 4 days in about 25% of patients, 5 to 7 days in about 46% of patients, and greater than 7 days in about 29% of patients. And they all defervesced within 24 hours of starting antibiotics. So this study concluded that the infants who received short courses of antibiotics actually had excellent outcomes, suggesting that prolonged hospitalizations on parenteral antibiotic courses or prolonged parenteral antibiotic courses actually may not be necessary in many cases. I'm sorry?
How long were the courses? Like 5 days, 3 days?
So less than 4 days was the first group, 5 to 7 days, and then greater than 7 days. And they were talking about the ones who were less than 7 days. And then the last study that I wanted to bring to your attention, I'll kind of just quickly go through this because I know we're crunched on time, is about, it was done in 2011, and they evaluated the necessity if we needed to do routine LPs in infants between 30 to 90 days of age. And really what they found was that the study included 392 infants, and 52 of them had one culture that was positive, 46 of them from the urine, 5 of them from the blood, and 1 of them from the CSF. And 7 of them had 2 cultures that were positive, 5 of them both urine and blood, and then 2 of them from CSF and blood, and 1 from all 3. in the entire study. And what they concluded was that routine LPs actually might not even be required in infants between 30 to 90 days of age if their urine analysis is compatible with a UTI and they're considered low risk according to the Rochester criteria. So please remember that the current neonatal fever guidelines are under revision. We're not sure when they're going to come out, but they are under revision. Questions? Yes?
Quick question to you. You talked about all these labs, but did not make any mention of CRP.
So actually, I didn't see anything when I was reading all of the articles. They actually didn't mention anything about a CRP.
One other comment. What about the babies that have hyperpyrexia, when you have temperature 104.5 or higher? How are you going to handle those differently?
So I'm assuming that we would probably handle them the same. And again, hyperpyrexia is rare. It's actually really rare to see that happen.
An example, we got recently involved with a child who was transferred to us about 14 days of age from reporting hospital, recovering from NAS, and then had a temperature of 104.5.
Oh,
Everything came back negative based on the suggestion that they have spinal tap, everything. Spinal tap is traumatic times 2, had high proteins, so we could not make any judgment based on the cell count. But the CRP was 186.
wow.
And he stayed high for 5 days with everything negative. So there, question comes, do we treat with insulin gentamicin? Do we add cephalosporin to have a broader coverage? That is cover gram-negative. So we did insulin, gentamicin, and cefepime
Oh, wow.
for almost a week.
Yeah.
And then the CRP stayed elevated for 5 days.
And did you trend it down? Did it eventually trend down with all three?
It eventually turned, I think it returned to normal range, less than 10, I think within a week or so. But these are kind of unusual situations, you know. A lot of people are now recommending the CRP and even procalcitonin would be another support that you can have
Yeah.
before you send the child home.
Right,
But this case was unusual because it's a high risk.
right.
Maternal septic use, all kind of other associated stuff. But we did not start an acyclovir because the PCR was negative from CSF. That was reassuring because there were no skin lesions.
Right. And the LFTs were normal too?
LFT was normal, you're right. We did those, and we did the viral panel too. It came back negative.
That's,
Thank you for a very good talk. In terms of CRP, I have seen that there are some studies that have looked at CRP compared to neutrophil count and compared to total white count, and generally it does perform better than those even in young infants. However, Dr. Kalra is absolutely right. They've never been incorporated in any of the guidelines that are currently published. I think it is being looked at. We got a sneak peek at the most recent East Hospital Medicine meeting of what the guidelines may look like coming out. It's very much going to emphasize children, it looks like, under 60 days, but really the big break point is the kids under 1 month of age versus the ones over 1 month of age. And I think your case also illustrates that these are just guidelines, and I think it is fascinating that they were published 25 years ago and we're still using them, but as you mentioned very well, the disease epidemiology has changed quite a bit, but there's always going to be exceptions to the guidelines, there's always going to be kids that don't quite fit for this reason or another. And so I think you have to know the guidelines and perhaps be explicit when you are deviating for one reason or another, but have good clinical reasoning why you decide to do something different. And a kid with a fever of 104.5 and a CRP of 180 is a kid who you might choose to treat differently, even outside the guidelines.
I think it's an excellent quote, not just very good. It's excellent talk. I hope somebody, because of the ETIs, will do an ultrasound.
yes, I hope so too.
Someone will do ultrasound.
Yes, Dr. Hollinger?
I agree with that. You mentioned the respiratory viral panel as being kind of an optional thing, not really excluded in that. Has anybody looked at, or have we looked at the utility of it in these babies? Like so for instance, if the respiratory viral panel is positive, are we less likely to have a serious bacterial infection? Can we
So It does depend based on the age. I think that it's a good thing, and the only reason that it was kind of as an optional thing was because I know for a fact that it's available here in our facility or in any other MSHA facility. But I don't know, like, going forward, if it would be available at my facility where I would go and practice. But if it was, I would routinely obtain them because it does give you a source of an infection. But for those kids who are less than 28 days, we'd probably, even though we have that source of infection, we'd still want to watch them for about 48 hours. But then if they're above that 28 days between like the 28 to 90 days of age, if you have that source, you can always just say, well, we have a source, we can watch the cultures for 24 hours and then let them go home.
There's one study that looked at this, I think, and the rates of UTI were actually about the same in kids who were positive for RSV and rhino, surprisingly. So my take, but there were no cases, I think, of meningitis in that study. So because UTI is the most common, I still will often, unless it's a little bit older kid or whatever, still go looking for the UTI.
What else? Okay, thank you.
All right.
Those are my references.